Good afternoon, all of you. First of all, we have to thank the organizing committee for giving us this opportunity to present this session on the magic bullet called MIGS, MIGS, a stepwise video demonstration. Of course, all of you know very well that glaucoma surgery has gone so much of changes in the past 3 or 4 decades. And of course, in the recent 2 decades, there's a tremendous development to find out to alternate to our conventional gold standard partial thickness trabeculectomy. So in that now MIGS has playing a major role nowadays, but we don't know about the long-term outcome of this MIGS. So to answer this and also to know stepwise procedure of this novel technique, we have a galaxy of speakers, including my friend, Brother Dr. Venkatesh, Dr. Madhavi, Moideen, Prasanna, Murali, etc. All people, they are actually doing this procedure. So they will be the correct person to present and also clear our doubts. So first I request Dr. Venkatesh from Aravind Hospital, Pondicherry, CMO, MIGS, because he is the one first to introduce MIGS to our part of our country. He brought Dr. Grover to Pondicherry and had a surgical demonstration. After that only it is picked up very well. So I request Venkatesh to give a talk on MIGS, a paradigm shift in glaucoma surgery.
Thank you, sir. It may not be a magic bullet, no? I mean, there is no magic bullets for glaucoma, unfortunately, but this will also have a role because we know, glaucoma surgery, when you talk about traps and tubes, we're not very happy doing that for a lot of reasons, so it doesn't stop just for surgery, immediate post-op, late post-op, even after 5 years, 10 years, you have a lot of issues. So whenever we talk about glaucoma management, right, in any practice, you increase the medical therapy because now we have so many medications. So you keep increasing 1, 2, 3, 4, sometimes a combination of that. And if you really count the number of medicine, it may be even 5, 6 sometimes. And then in between you have laser therapy, the ALT or SLT. And then finally we'll end up doing a trab or a tube by the time the patient's glaucoma is very advanced. They either have quality of life affected because of glaucoma or they have an advanced damage, which really bothers them. But where does MIGS come? Your MIGS will definitely have role much, much earlier. If the patients are not able to tolerate medications or they are not able to kind of afford for their medications, you can still consider doing procedures like this because we need something which is highly safe, which is less invasive because you can preserve the conjunctiva for future surgeries and something which has got a very quick recovery. But we have to keep in mind that there are surgeons who can even do on narrow angles and angle closures, but you have to keep in mind that most of these approaches, the ab interno approaches, are for open angle glaucoma. That you have to keep in mind. You need the angles to be well opened. It may be narrow post iridotomy, it's open, you can still do, but it's mostly for open angle. But the most important thing is all these points which I just highlighted. Where do you really fix this procedure? You can't do it for somebody with an advanced glaucoma with a very high pressures. It may not really work. So when there is mild to moderate glaucoma, when there is mild optic nerve damage, you can do this standalone or you can combine when you're doing a cataract surgery. And keep this in mind, that most of these cases, your angles have to be really open. What procedures you have at this point? They're talking about Zen, which is still not available. But the enhancing the Schlem's canal is one thing which you can all try when you're doing a glaucoma surgery practice. Now, there are several things which are available in your hand, including trabectome, you have eye stents, hydrus is still not there, you have the gonioscopy-assisted transluminal trabeculotomy, the Kahook dual blade is available, and there are a few other procedures which are experimental. I don't want to get into that, but many of them are these ab interno, where you just get into the canal, or like enter the dragon, you enter the canal. And the suprachoroidal, you had SIPA sometime, it's gone, but iStent Supra is there. And of course, you have ECPs, and very few people do that. And mostly it's again done for intractable glaucomas. So when you talk about MIGS at this point of time, what is really there for us. Some of these options are viable and it's available, especially the Kahoot dual blade, where you can open up the angle nicely, where you can really play with the Schlemm's canal and the gonioscopy assisted transluminal trabeculotomy. Some of my colleagues who are doing a lot of cases on this will show you step by step. But the GATT, which was again introduced by Davinder Grover, who is a very good friend of us, when he came for training, he said, this is a procedure for developing world. Because you can do this with the suture. You don't need this expensive catheter which you see here. No, this is again, it's an expensive for each case you have, but you can do this with the suture. And now we find that the suture results are even much better than the catheter. So what do you really need for this technique? You need a low temperature cautery. You can buy this on Amazon. And then you need a good gonioprism, a Swan Jacob, a phyoprolene suture, a MVR blade, a very good viscoelastic. We use Orogel. We are very comfortable, equivalent to Helon GB, MST forceps and McPherson forceps. We'll just quickly see a case. Now, I'm not going in detail, step by step. Some of my colleagues will cover, but it's actually, it is a little bit, there is a learning curve. Now, you can't just go ahead and start doing a GATT. You may have to touch the angle first. You have to see the angle first. You may have to open up the trabecular meshwork and look into the canal, and then you can do this. So this is basically a prolene suture, which is used to go inside the Schlemm's canal, and that's the low temperature cautery. When you use that low temperature cautery, you have to make sure it is slightly away from the suture so that you have an ideal flange. And so this is called a flange, where you make a small snub there. Whether if you do a combined or a standalone, depending on what, you can make a corneal incision, and one on the side port for the suture and the other is the main tunnel. And this is very, very important. Looking at the angle is very important. Now, if time permits, I'll just touch upon that. But basically, you have to see the angle like how we see here in this beautiful video. And you don't like blood anywhere, right? But if you get blood here, you should be happy. That means you have opened the canal and the blood is coming from the Schlemm's canal. So once you see the blood, you clear the blood. That is very, very important. If you clear the blood, then you will start seeing that whitish area. From your brownish trabecular meshwork, you will see a whitish area, and that will give you a clear idea that you are going into the canal. So whatever procedure you do, it's like the trabectome, the KDB, everything works on the initial nick which you make. And this is the suture which is going inside. So once it starts going, you can beautifully see the blue suture going in, and you can really play with the angle that you can believe that it comes all around like a 360 degree. But you have to be very meticulous in these steps. You have to go very, very slow, clockwise by clockwise. Sometimes in between, we may have a doubt whether it's in the canal or not. So you can confirm by putting another lens, like a direct lens, and seeing. But most of the time, once you are confident, you can see that the suture is on the other side. And that's the point when you have to really bring it out through the initial nick which you have made, and then you have to grasp the suture on top of this suture. That's very, very important. You have to grasp it on top of this suture, not below, then it can get entangled. And once you have a nice grip, then you make the 360 degree trabeculotomy. That's very, very important. So you grasp it like that, you pull the suture, and then using the McPherson from the other side. This is the real trabeculotomy which you are seeing. This is how you do the 360 degree trabeculotomy. And then the McPherson goes to your other side, and then you pull that suture. That will tear the trabecular meshwork all through 360 degrees. And the same way, you can do several other techniques, especially the dual blade. But the colleagues here will describe some of these techniques in very detail. But basically, you have to start seeing the angle to do a good MIGS. And once you start seeing the angle, you touch the angle with whatever you have, Sinski, Cyclo, and then you start opening the trabecular meshwork and seeing the canal inside. And then you can play with MIGS. That is how our learning curve has been. And many of the time, the learning curve has been smooth once you do a proper intraoperative gonioscopy. Thank you.
Thank you, Dr. Venkatesh, for a brief outline of MIGS and how it fits into our population. Next, I would like to request Dr. Madhavi, who is a glaucoma consultant at Aravind Hospital, Tirunelveli. She'll be giving a talk on ready to kickstart the nuance of intraoperative gonioscopy. With me, Dr. Sugashini, Professor of Ophthalmology, JIPMER, and Dr. Devendra, Senior Consultant, Glaucoma Service, Aravind Hospital, Tirunelveli.
Good afternoon, one and all. At the outset, I would like to thank TNOA for giving me this opportunity. And it gives me great pleasure to be in this podium as three of my mentors are here. Immediate past president, Dr. R.K. sir, my MIGS mentor, Dr. Devendra sir, and my chief, Dr. Moideen sir. So let's kickstart this journey of minimally invasive glaucoma surgery by learning the nuances of intraoperative gonioscopy. So MIGS, which initially started as a bridging procedure between lasers and glaucoma filtering surgery, now the spectrum keeps on expanding. So these procedures are minimally traumatic with good safety profile and good IOP lowering and a rapid recovery. They target the conventional outflow pathway through the Schlemm's canal. So they act on various sites which include the trabecular meshwork, subconjunctival based or suprachoroidal space. The device-based MIGS in India is limited by their availability and expensive nature. Some of the devices are just coming up in India like the iStent, but Hydrus and Sengel are yet to come. While the trabecular meshwork based procedures have gained momentum, being readily available as well as economic. So now we have an array of minimally invasive glaucoma surgery procedures being done in our institute. So before all that, be it any MIGS procedure, the first stepping stone is the mastering the art of intraoperative gonioscopy. So for that, preparation is the key. So the surgeon should prepare by performing gonioscopy in clinic before starting the procedure and identify the landmarks. And also, before starting minimally invasive glaucoma surgery procedure, you should have thorough intraoperative practice. Routinely practice after your normal phacoemulsification. Then you can able to identify the landmarks. The patient should have good neck mobility without any head tremor, being good cooperative, and angle should be visible in the clinic. So the initial patient selection should have these criteria. Next is the patient and the surgeon positioning. So the microscope should be tilted towards the surgeon, around 30 to 35 degree towards the surgeon. And the head of the patient should be rotated 30 to 35 degree away from the surgeon. The next important step is the patient bed positioning. Here we have to have the reverse Trendelenburg position, that is keeping the head above the heart. As sir said, there will be some amount of bleeding when you are starting the minimally invasive glaucoma surgery procedure because you are going to open the Schlemm's canal. So you are going to expect bleeding. But still you want to have a good view. This helps prevent the blood reflex from the Schlemm's canal. Apart from that, you should have good anesthesia. So in this video, you can see there is some amount of struggle to get a good visualization of the angle because of the poor anesthesia. Because the positioning is very, very important as far as any MIGS procedure is concerned. So now the visualization is not there, but the visualization, once it comes, the eyeball is rotating. So the instrumentation becomes very difficult. Next, we have a wide variety of lenses, including the handheld, hands-free, floating lens. And now we have the direct visualization Ahmed lens as well. So apart from a good gonioscopy lens, you should need a good high density dispersive viscoelastic as well. So next is docking the gonio lens. After applying good quality viscoelastics, one has to hold the gonio lens in the non-dominant hand. The hand or the wrist will be resting on the patient's forehead or the chin depending upon the laterality of the patient. It is very important that you rest the rest on the chin or the forehead of the patient because your hand is going to be away from you. Next, after putting the gonio lens, make sure you identify the landmarks before starting the procedure. So for beginners, you can just practice the gonioscopy and just identify the landmarks and then try touching the trabecular meshwork before you actually venture into the minimally invasive glaucoma surgeries. The goal is to achieve an en-face view where the light should be parallel to the iris and pointing towards the angle. So these are two videos. So in the first video, when you are putting the gonio lens directly on the cornea, you are not able to see any angle structures. Now the microscope is being tilted. Still you won't get any view. Then the patient's head will be rotated. But still you are not getting a clear view because the structures are overlapping. The point I am trying to make here is adequate tilt of both the patient as well as the microscope is needed to get what is called an en-face view. So in this video you are seeing after application of the viscoelastic, now you can see a clear en-face view with the clear separation of the angle structures. So there will be a lot of hurdles along the way when you are starting your intraoperative gonioscopy. The angle space, this is very narrow. Compared to the phaco surgeons, we have around this space, 2 to 3 millimeter, while as angle surgeons, we have only this space to manipulate. So we tend to damage the iris or the cornea very easily. So that is the margin of error is very less, and that is why it is very important to master intraoperative gonioscopy. The other difficulty that we tend to face is the simultaneous intra and the extraocular manipulation. Because one hand which is going to be away from you, while the second hand you are going to do the surgery. So this is the simultaneous intra and the extraocular manipulation. So next you are going to operate under very high magnification. So with very high magnification you are going to lose your resolution. So it is very important that you operate you have to master the gonioscopy very well. So here you can see the difficulty in instrumentation because of the problems with the magnification. So if you are not keeping the microscope and the patient's head in proper position, you may fail to achieve the en-face view. So let's look at some troubleshooting videos. So another thing is you should not put undue pressure on your left hand. That is a non-dominant hand. So if you are putting undue pressure on that, you will tend to have these corneal folds which will have difficulty in visualization. So next you should remove any bubbles that is there because again these are going to pose trouble for visualization. Apart from that, blood is a good sign but clear it off before you actually go for the procedure. So still blurry, check whether it is too zoomed out, check for your accommodation, patients having conjunctivochalasis or corneal edema, again the vision can be blurry. To summarize, with going popularity, the technique of intraoperative gonioscopy one has to master. So the ultimate secret or the key is constant practice. Thank you.
Thank you, Dr. Madhavi, for those excellent tips and finer points to refine the technique. So the most important point that we learned is mastering intraop gonioscopy. So we'll move on to the next topic. I'm really waiting for Dr. Mohiddin's talk. So I heard that he does a lot of GAD rather than traps. So threading the right way, suture GAD decoded. Over to you, Dr. Mohiddin.
Yeah, I think, thank you, Chairman, Co-Chairman, and I'll be talking about GAT with the suture. So I think I'll not go to waste time. I think already Venkatesh has covered. I'll just go to some of the case scenarios. This is a GAT in advanced glaucoma. This is a case of a 60 years old female, a known PAOG since 2000, has a maximum nickel medication of course of alpha and Xalatan. since 2003. That IUP is 21 right eye and 19 left eye with a low CCT, and gonioscopy open angle. Fundus is point in the left eye and near total in the left eye. So this is a field defect of the patient of 10-2. The tubular field, the split fixation in the right eye and near to the split fixation in the left eye. And see the doctor from Doha, and see the active, and see the target pressure. We want to set the target pressure below 14, and CT capital is a point in tubular field. I say refer for trabeculectomy. So what do you want to do? So I thought I will not do trabeculectomy because advanced glaucoma, you can have some problems. So I done a GAT for her. This is an angle for her. This is low trabecular pigmentation. In the low trabecular pigmentation, sometimes difficult to identify the slums canal. Just go nick, just hand it to the whatever the trabecular mesh you see, and just use a 24 needle or a 26 needle. You depress, you make a slums canal. Once you see a slums canal, you can just see a sutures go very smoothly because of the less trabecular mesh work. You can able to the suture is going. This is an unedited video. I didn't edit this video. This full GAT. If you go smoothly and the sutures go little firmly, after 180 degrees, you have some firmness to push the suture into the canal. If the suture goes very smooth, then you're not in the canal. So after 40 stripes, and the forceps I'm using the Nascaris forceps, after 40 grip, then strike, then you will be able to see sutures going to come out. So you're sure if you're going to more than 270 degrees, you have some more resistance you'll have. But be persistent. And I didn't, my AC is well formed. So once you get the suture out 360 degree, then I'll put the suture outside. Then you will have, this can have a lesser, you will have some bleeding expected, especially following GAT. But luckily this didn't have very heavy bleeding. So we just put some air bubble, then we put some viscoelastic. I just wait for 5 minutes, then again I wash again. So look for any bleeding. So because the post-op bleeding is a very common complication following GAT. So once you feel I'll find the no more bleeding, I put some air bubble. Then I use an aerogel. This aerogel 1.4%, not a plus. I just go behind the air bubble and just put this aerogel along the air bubble. Then I tighten it very tightly, and I put and I just come out. And the post-op, the pressure has become 10 or 6 month post follow-up. Look at the other eye. We didn't do any GAT at 18. She came back again after 6 months for other eye GAT. So we done GAT for both eyes. Our pressure is 11 right eye and 9 in left eye. And so the Pilacar hatches and dorsalamide twice a day. This case number scenario where the GAT and PAOG with high trabecular pigmentation. This is a 70-year-old male patient with 6-line vision. Pressure is 23. He had a very high trabecular pigmentation, NS2, and we done a combine, and a pointed cup in right eye and points in left eye. This is an nasal stop in fields in right and left eye. This is a case of a highly pigmented trabecular meshwork. We just make a nick at the anterior to the pigmented trabecular meshwork. You depress this nick, then you see a slums canal. So once you see a slums canal, be ready with the suture. This pass the suture 360 degree. So the suture has to go firmly. To go very smoothly, you're not in the canal. So one more thing is, other thing is the bleeding will come. You again refill this anterior chamber with the Aerogel Plus. So Aerogel Plus is 1.6%, very important to deepen. And once you clear this media, then you can really see. Then also the one more sign is you are in the canal. They can see a reflex bleeding from the opposite of the canal. It also shows that you are exactly in the canal. So this again is the patient. Again you just wash it out. If there is more bleeding, so wash it out. Her post-op pressure came to 10 mm mercury in 3 months post-op from 23 to 10 with not on any medications. This case number 3, this is a journal glaucoma. This is a 20-year-old patient referred from Kerala. Her pressure is 41 right eye and 28 left eye. A gonioscopy open angle and 0.8 cup in right eye and 0.8 in left eye, which is a Brinzong and Ganford in both eyes. This is a coverage ratio of the patient of 0.8 and 8.5 and 0.8 in left eye. And this is the field of the patient is affecting the central tubular field, also central macular split is coming. The left eye of the patient. I done a surgery. This is the OCT of the patient, the right and left eye. And I done a trap with the mitomycin C in some time back. And the post-op, she had a 6, in the 2 weeks post-op, IUP 6, we were happy. At 2 months post-op, she post-op 4, and then she developed a hypotonic maculopathy, the 0.8 cup. So at the 3rd month, she comes back to me and asking me, so my pressure in the left eye is 45 mm mercury. And she has a cat in the right eye. What do you want to do for the left eye? I told her, I will not do trap for your right eye, and I do GAT for left eye. If you done a GAT for left eye, this is the phakic eye. Okay, I use 2.2 keratome to enter the anterior chamber. I make 2 side port, and I just make put a viscoat over the cornea for the coupling solution. Then I use a 26 as needle. Just make a nick anti to the tubercular measure, pigment tubercular measure. Then I depress my incision, goniotomy incision. Then I say nice lumps canal, ovitus canal. Then I put my 50 Prolin suture. So once you put Prolin suture, again it has to be it has to go firmly, not smoothly, and just be gentle and just keep going. So once you go more than 1 degree, you have some resistance. Again, be persistent. Deepen the AC with RGL plus. Then you get the suture other side, and you're happy to take it out. So once the suture is out, then you pull the suture back. The distal net is pulled out. So as Venkatesh was saying, just go over the suture. Don't go below the suture. Sometimes you can DM tear can happen. So once this suture is out, then you are happy to finish this gap. I have the post-op. Look at my right eye post-op. Post-trap. The pressure is 4 millimeter mercury with hypotensive maculopathy. The left eye is pressure is 12 without any medications. This is the post-op of the left eye of the patients. The case number 3, I done a just goniotomy and GAT and congenital glaucoma. I just tried. I don't know, see the 3-year-old microcephaly patient, craniosynostosis, development delay, on my side and attack in the left eye, a post-GAT in the right eye. So left eye has 34 millimeter mercury, a 30 millimeter diameter, corneal diameter, mild corneal edema, and the poignant curve. The axial length is 22.63. And this is a video of the GAT and congenital glaucoma. So I just say you had 2.2 millimeter keratoma entered, then made this one side port, and I made 2 side port on the periphery for the sutures to go. Then I just use the blended tip. Only thing is you must not touch the tip. If you touch the tip, then the mushroom is very big. You don't touch the tip. Then I just there's a tubercular and also dysgenesis available. So you can just make a nick over to the pigment tubercular measure. Then I put the sutures in. Let me try. So I tried, but the push is very hard, especially in the congenital glaucoma cases. Really need to be really high push. Then I tried the maximum push possible, but I know it's in the canal. If it is in the canal, there will be little more resistance will be there. If it is not in the canal, it will go just smoothly. So I tried the maximum possible push. Then at the end, I know the lot of resistance are there. Then I put some push, some more push. Then at the end, I just remove the suture. I have interno. So when I remove the ab sutures, the forceps I use the masculine forceps. So once I know the maximum resistance, then I just pull the sutures. Then you can see a nice goniotomy incision, nice tuberculotomy incision. Then I do this 270 degree. It came up to that. Then I didn't leave this area also. Let me try other area. I went from other side. Then one more 190 degrees, and that's completed 360 degree gap. So this also I just made. Yeah. So I just removed that. On the end, I need to suture this wound because of a pediatric case. I just used stenovicryl to suture the wound. So the post-op pressure was 22-24 on day 1 and 22 and 15 days. 1.5 months when we stopped steroids after 4 weeks, the pressure came to 10. So there are some people high steroid responders that keep in the mind. So my 10 key steps, like what Venkatesh will say, need a good microscope that tilt, zoom, and foot pedal control. I need to relax, be gentle, and visualize the angle anatomy well. Use a Swan-Jacob direct gonal lens. Use high viscosity RGL plus 1.6% sodium hyaluronate to deepen the angle and anti-chamber. No final interest. You blend the 50 Prolin with a small mushroom tip. Use a low temperature cautery. Use 2 paragons on either side. Use viscose for gonio coupling solution. Use masculine forces from retina colic for threading the sutures. Goniotomy is the key. Make incision anterior to the pigment tubercular measure. Use either 24 or 26 needle. Deepen the AC in between threading. Like use RGL plus for proper vision of the angle. Clear media for easier threading. And also look for reflex bleeding from the goniotomy side. I conclude saying that GAT is a promising initial surgical choice for POAG, JOAG, even I use advanced glaucoma field loss. IFEMA the most common post-op complication. A long-term IOP control need to be studied. Thank you. I also thank my colleague, Geeta Korean, for helping with the slides. Thank you.
Thank you, Mohin sir. I think excellent presentation. I have the wonderful videos. But in the journal, I would like to comment, when you start the GAT kind of procedure or any MIGS procedure, please select the mild to moderate glaucoma. Once you become a master, then only you will go for the advanced glaucomas. Apart from that, when we talk about the juvenile glaucoma, the anatomy is not very clear, and really we have to be very master in doing the MIGS. Then only we should try the juvenile glaucoma, especially developmental glaucoma. They are really challenging. I think we should keep in mind. Then we should go for MIGS. So now I'm going to call the next speaker. I think everyone know him, Prasanna, most dynamic, innovator, and creative surgeon. Okay, welcome to Prasanna. And he is going to talk about something again tricky, getting the mark with iStent, KDB, and Bang. Don't mix all in one case. Carry on.
I think I have also, sir. Let us go to hitting the mark with the next few implants. So I'm Dr. Prasanna Venkatesh Ramesh. So my journey started in World Glaucoma Congress in Australia 2019, and I'm yet in the process of MIGS, and I'm learning a lot from seniors like Venkatesh sir and Devin sir, etc. And these are some of the approaches. I'll just skip the introduction part and let me keep it fully video based so that we'll have a good vast session. And I'm sharing few of this from the publication of mine this year in February 2023, Indian Journal of Ophthalmology. So I'll skip this part of direct gonioscopy where we tilt the microscope, and recently I just learned this technique that Arvind from Venkatesh sir, they're also doing this. We recommend that you can just have a mark so that before and after your OT assistants will really know how to tilt the microscope 30 to 40 degrees towards you. And then you end up shifting the patient's head another 30 or 40 degrees away from you. So these are all the basics, and you may use whichever lens of your choice. I'm using a TVG lens and a glucose lens, and the basic videos of visualization, hand-eye coordination. So this is one technique that I would recommend my fellow phaco surgeons here who are attending. In the initial days, I started with just placing a TVG lens. You can see the good docking that is here. You can move the lens, you cannot lose visualization of it. And I started taking a simple Sinski. So tomorrow, if you have a direct gonio lens, no financial disclosure, you may get it up to 5,000 or 6,000 rupees. With a Sinski hook, you can end up tapping the trabecular meshwork, and you yourself can orient yourself and train yourself towards the magic bullet that we are discussing today called MIGS. And just to add on to it, just replace your Sinski hook with this particular needle that you use for capsular excess, a 26.5 gauge needle. You just bent it the other way around. You just see me doing it the other way around. And then you can see you have already trained yourself with a Sinski hook. You have good visualization. Now you can just swipe it left and right. You just need to identify the trabecular meshwork here. And I'm just forwarding this video again. You can see now I'm going the other way around. So this is like 100 to 120 degree. You are just swiping the trabecular meshwork or deroofing the Schlem's canal. It's called BANG, bent ab interno needle goniectomy. So it just costs nothing. It's a very economical procedure. And you can see that in the post-op, a beautiful cleft of the opening of the Schlem's canal can be appreciated. Then talking about the Cahook's dual blade, again this is a much better refined version of a bang. In a bang, if you see, it's more like the edges may not be much well refined. I'll show you the animation of the same. So in this you can see that this is a much controlled excision of the trabecular meshwork, and in this area I would like you to note that this is more like a peripheral anterior synechia, or it's slightly an angle closure. Again you can see that this is me performing a KDB here, which will also help you to release at least synechia at the level of the pigmented trabecular meshwork in at least my hands. So again this is the animation of the same. You can see that the edges are more controlled. It's a dual blade because it has two sharp edges which helps you in lifting and stretching the trabecular meshwork, and then you can have your flow. You can see that you can have a beautiful flow, and it's more controlled compared to a bang. It's just similar to a bang, but the blade is slightly more controlled, so you'll have a much better control. You can have three different techniques. One is called the outside in. You can come from the outside, you can mark it, and then you can come the other way around, or you can mark from the inside. You can go inside out. I'll just show this animation also. You will mark inside and you can go the other way around. So this is the inside out. And the third is mark and meet. You can mark a point in the center and then you can come and meet that particular point. But whatever said and done, 100 to 120 degrees, if you are lucky, you have a wide field gonio lenses, or if you have a good right technique of understanding, you may be able to get 140 degree also or more than that. So I'll leave the theory part. Let us have a good vast discussion. These are definitely the suggesting good results. So this is some of the case series of iStent that I would like to show. Moving on to the third part of the presentation, I'll just start with the G1 series, the generational 1 series. So this is due for publication, this 8-minute video in the Indian Journal of Ophthalmology. So I'll just share this collection for you here. You can see that this is the G1 that I'm placing. The trabecular meshwork is more pigmented, and this is a visual marker. You'll just have to orient yourself to the anatomy. So once you orient yourself to the anatomy, anatomy is the main feature, my dear friends. Then you can place the stent. In this particular case, I just wanted you to note this observation. So once I place the stent here, I was able to identify a tiny blood vessel in the hand track appearance, which perfused soon after on the table. So these are some telltale signs which started guiding me that, okay, these are some tissue behavior that I need to make a note of. I'm not only sharing the good cases, this is just a journey of mine. In the initial stages, you can see that I did have many difficulties. The trabecular meshwork, each meshwork was different. Attempt 2, attempt 3. Sometimes I did have difficulties in placing the stent. It just cheese wired, as you can see here. But you will always be able to understand, just like the Rexes, you will understand that what is the pressure of that particular meshwork, and you can end up placing the stent. You will just, it's a matter of just learning. And confirming the position of the eye stent. So this is a nudge technique that we have published in the nudge sign. So once the eye stent is placed, you can see that I'm not very sure whether it is in the trabecular meshwork or whether it's in the wrong plane. And you can see that the bleeding is also not really going to help me. So I've just taken a Sinskey hook and I just retracted the root of iris slightly below, and you can see beautifully the scleral spur is below. So that helps me guide that, okay, this is where the eye stent is actually really placed. The nudge sign also really works. So these are some simple tips and tricks I wanted to share. Again, this is another rebound. I'm not sure whether it was a trocar malformation or whether the stent had an affinity to the trocar. I'll just show this where you can see when I place the stent was just not releasing. You can see this video, I'll just show it once again. I tried to release it, but you can see the dancing sign. The stent is not releasing. I don't want to drop the stent. I'm not very sure. So I'm not sure whether it's in the right plane or not. So I'm again catching it, and again I'm trying to make sure I push it in. So, but again when I'm trying to release it, you see the stent is just not trying to come out of it, or it just comes out. So these are some of the things that really happens. And then I was able to assess the scenario, and then I found out that it had a mild affinity. So again you can see here the trabecular meshwork was more sticky, that you can see when I'm releasing it, it just actually catches it and then it rebounds. I'll just show this again. It's a very minute sign. I hope you'll be able to see. It again recoils like that. So that trabecular meshwork was more elastic and was more sticky, and it's more transparent also, as you can see here. So that was one of the cases. Again, these are all the learning that will happen. And as I told Devin sir, again we are having this particular thing of combined mix where the stent is placed and 2 clock hours away. For some of the cases we are having a data on it which is due for publication. Along with the stent, we are doing a 2 clock hour away bang as well as a KDB. Once the stent is placed, you can see again, the previous video was KDB. Here you can see me performing a bang after 1 or 2 clock hours away. At least with the results we'll be able to see whether how things stand with a single procedure versus a combined mix. Or you may be heard of a combined cataract and a glaucoma surgery. This is a combined mix. Again, this is a second generation eye stent where we need to dimple and then we need to inject the stent in. And after a 2 or 3 clock hours away, you can always place the second stent. One telltale sign I was able to identify in this case is once the stent was placed, you can see a good paralimbal blanching between the 2 stents that has been placed. So these are all the signs that actually it is working. The tissue is actually responding in that way. And again, this was one of my complicated cases. I first placed the stent and I'm thinking that I'm in the right plane, and I'm like, okay, fine. Because we all know it's all very costly. And once when I injected the sodium hyaluronate, you can see me that this was a heart in the mouth moment for me. It just dislodged. So I had to reassess myself and I had to make sure I placed the second stent first. The dimple now is much more. Because I burned my hands in the first implantation, now I understood that this particular trabecular meshwork needed a much bigger dimple. So I made a much better dimple and I placed the second stent first. I have 2 more clicks remaining. So I recovered the second stent, and then I was happy. I thought I'll just come out and then again go back in. Again when I came out, I again saw to my surprise the stent was again missing. One mistake I did here was I forgot to close my trocar before I took it out. So luckily the stent was actually in the phaco wound. So these are all I'm sharing so that beginning we may all be making some mistakes and it's very costly. So I was lucky to recover the stent and again go back in and have my implantation done for this patient. So the eye stent was retrieved and the patient is happy and the results are doing good. And we are also having our simulator, which I have shared in many forums. You can always come and practice in my simulator. And to add on and to touch on to a point on the next thing that is always there is the ECP. So recently we have started this, and this is also seeming to show good results where there is a whitening of the the ciliary processes, where you can see a beautiful whitening that is being happening when you place. So these are all the MIGS procedures that are available, which I had covered, what my previous speakers have not done. The results are all promising. And to move on, it is very promising. We save the conjunctiva. The IOP control seems to be very good. Even for post-tube and a post-trap patients, even suture GAT seems to be very promising. And I think time will tell where we stand according to the different MIGS implants that we are having, or the different cost-effective implants like Bang or suture GAT that we are using. But it seems to be the future, and this seems to be where we are all heading to, because less complications, we save the conjunctiva, and the results are very promising. Thank you once again for the opportunity. Thank you.
Thanks, Prasanna. Very nice videos. In the interest of time, we'll move on to the next talk by Dr. Muralidhar. Does less invasive mean less risky? We'll keep the discussion at the end.
Okay, I thank the scientific committee for having invited me for this wonderful symposium. So I'll be taking a perspective on GAT, and I wish to acknowledge my mentor, Dr. Craig Chaya, who had taught me and was with me throughout this journey on GAT. GAT, much of this has been covered, that it is bloodless, it leaves a pristine conjunctiva, possibly more physiological, and targets the pathology in some of the secondary open-angle glaucomas. And you actually relieve 70% resistance to the aqueous outflow if you cleave the trabecular meshwork. The remaining 30% is in the collect channels. So if you go to the review of literature, these are many of the studies that we had quoted in our article. So GAT gave an overall success of around 90% at 1 year. 96.3% at 1 year. That was what we had reported. So the indications, mild to moderate, definitely yes, open angle glaucoma. For secondary open angle glaucoma, any grade. For queries, severe primary open angle glaucoma, I just put 2 queries. Possibly we use this whenever the patient has not been on topical anti-glaucoma medications for a long time. Primary angle closure glaucoma, as Sir said, if you are able to see the nasal angle, and the others remain a little experimental for trab and tube failures. We have tried for quite a few trab failures and have got fairly good results post penetrating keratoplasty when you are able to see the angle. And we use this only, like we don't do it for just because the patient has a glaucoma. We do it only when there is poor IOP control in spite of medications, or he or she is non-tolerant or non-compliant to medications. If there is a PCR during surgery, or if there is a luxation of the lens, or if it is an SFIOL, it is better that you avoid this angle surgery. And if you see here, I just put a PubMed search. The number of articles in GAT is steadily increasing. So as the previous speakers have said, there's no denying the learning curve. So this was one of the earlier videos. And if you see, as we go around threading the meshwork, so we use this marker suture. Those at Arvind, they are kinking the suture. We had used this marker suture. So as we pass this suture, you see that the other end has actually extruded. So you have to recognize this complication. You need 360 degree to get the bang, to get the maximum bang for your buck. So the suture, if you see, has started extruding here. So if you just pull it and leave it, you will not get the 360 degree angle cleavage. 360 degree is ideal for best results. So we've seen whenever we have done less than 360 degree, the IOP control has been suboptimal. You do get some IOP control, but it has been suboptimal. So once you do this, you have to go for a reverse cannulation. I'll cover this. So this was a patient with failed trabeculectomy, and so you can see the flat bleb there. So many years since trabeculectomy has failed needling also. So as we advance, so if you need to do a preoperative gonioscopy, and if you see the ostium is crossing the trabecular meshwork, you're likely to encounter some kind of a resistance. The suture tip is likely to stop there.
Marker suture is placed to gauge the progress of the suture. Fails to advance.
So after some time,
indicated by the position of the eye.
We did a goniotomy and retrieved the suture.
This position for a goniotomy.
So ideally we aim for 270 to 360 degree of complete closure, but you have to recognize the sign that the suture has stopped. If you continue pushing the suture, I used a marker suture here, you need to recognize that the suture movement has stopped. If you don't recognize, it can get misdirected and cause a false passage. And so that is the site of the ostium, and we were able to get around 270 degrees of GAT. So patient did very well, and because we got 270 degrees, so you need maximum degree to pack this punch. So it is not that you need an ostium for the suture to stop. It can stop even otherwise. So I'll just forward it for interest of time.
Stage is noted and further movement of the suture is not possible.
So in this case, you have to do a goniotomy. So you see the suture kinking there. So to recognize this, don't attempt to force the suture. It will only cause a false passage. So all this comes with learning. So if you are a learner, you need to recognize this sign. Otherwise, you will end up damaging the other structures.
Remember, 270 to 360 degrees.
So we pulled the suture out and then we did a reverse cannulation.
Therefore, a reverse cannulation is done and a stent canal cannulated in the reverse direction. Suture obstruction.
So you should know where to stop. If you don't recognize that, this comes only with repeated practice. And if you don't know this, you may end up damaging other structures on the inside in the anterior segment. So I'll just come to what all can go wrong. So by forward and reverse cannulation, we managed to achieve 360 degree, and 270 to 360 degree you need for a good this thing. So this is what happens if you don't realize that the suture has come out of the Schlemm's canal. So as we go on pushing, you see the pupil peak towards one side. So what has happened is the suture has come out and it's gone into the stroma of the iris. Fortunately, it was only the iris stroma this time, but it can also damage the other structures. So we did a goniotomy and retrieved, and while doing a reverse cannulation also, the pupil started peaking. So if you get a pupil peaking, that's a sign of suture extrusion. So again, this learning comes with repeated practice only. So this is some of the first day postoperative pictures that we had. So if you notice that the blood can go behind the lens, if it goes inside the capsular bag, it's not going to absorb. So the other bleeding, you can just wait and watch. This and this, you may actually need to go in and wash. And this was an iridodialysis when we did a goniotomy and retrieved the suture. So damaged, and this is a OCT picture showing a decimet scroll because of too much of manipulation in the anterior chamber. So all these complications can occur in suture gate. And this is a severe inflammatory reaction because we encountered a lot of difficulties in cannulating. So this is not a cataract actually, this is a severe fibrin membrane over the IOL, gradually resolved, and for the remaining we did a eye. And it caused quite a bit of posterior synechiae in spite of giving intensive steroids for this patient. So this is a very funny thing, I really don't know what happened. In a phakic patient, we did GAT, and then the suture, then patient had hyphema, and then we washed the hyphema. So when the patient came back with counting, hand movements close to vision, close to face vision, and then we saw that there was a total cataract. There was no breach of the anterior lens capsule when we did the cataract surgery. So this is the second case actually. Rapid progression of cataract is a known complication after trabeculectomy, but then we have encountered this after GAT. So I initially thought that for some reason we have punctured the anterior capsule, but there was no anterior capsular puncture during surgery. So this was a patient who presented with a shallowing of the anterior chamber, had fishmouthing of the side port because of too much of manipulation, and we went ahead and put a figure of 8 suture, also reformed the AC, and patient did very well. So this was one of the case scenarios. So this was a patient with macular dystrophy, young patient, fairly young patient, 40 years around. So left eye twice operated PK failed. The right eye penetrating keratoplasty was done. Had graft rejection twice, and then now fairly good cornea. So we did a GAT for this patient. Did not have any glaucomatous damage. Did not do a trap because there was some severe ocular surface disease. The angle was only open in a short area in the nasal trabecular meshwork. So we did it, and then 1 week when the patient came for review, we saw that the pressure was 33. We instituted anti-glaucoma medication, but this was the long-term pressure control. Have followed up this patient for 9 months. So this initial IOP spike is something that you need to be aware of. In this, it was a little dicey because the graft could have failed by the IOP spike. We were lucky because the IOP spike was controlled with anti-glaucoma medication. So you need to know that IOP can spike after GAT and can spike really high. So this was a patient with bilateral angle closure glaucoma. The nasal angle was open, so we did a GAT. Patient had not been on anti-glaucoma medication, very advanced glaucoma with macular splitting. So because patient was not on anti-glaucoma, we did a GAT, and the right eye did fairly well. In both cases, this patient developed severe positive pressure during cataract surgery, and we had to abandon the surgery and then reschedule GAT at a second sitting after giving mannitol. And if you notice here, the pressure spiked to 32. Eventually, he came to 10 and 16 without medication. So the left eye now is on timolol maleate. Followed him up for 1 year, and he's doing fairly well. So these were two patients with iridodialysis, which developed when I did a goniotomy, and I should have retracted the suture, but I just pulled it out, and then this resulted in a little bit of iridodialysis. So these are two patients with capsular bag hematoma. This very small, we did not do anything, but this big blood clot behind the PCIOL that required washing. This is the worst thing, that it fails to work altogether. This is last two slides only. So this was a patient with uveitic glaucoma, young patient, around 30 years old, did a GAT, complete failure, and then ended up receiving a trabeculectomy. For 6 months, it did not work. But when you compare the complications with trabeculectomy, the complications of GAT definitely are much, much less. Only thing is we don't have, good follow-up. Whereas trabeculectomy, we have follow-up of 30 years or more. Whereas for GAT, we don't have that. So we should wait for data to build up over time. But I would say that GAT definitely is a wonderful addition to our armamentarium. The other problem is, this is a patient with gonioscopy, which I had done. Even though 360-degree GAT was achieved, but the trabecular shelf is seen only in 90 degrees. So in some patients, even that 90 degree is not there. So if this patient, loses his or her medical records and goes elsewhere after a few years, says glaucoma surgery was also done, and there are no records, patient doesn't recall the name of the surgery, the other surgeon may just feel we have fooled the patient. So that's about it. Thank you.
Thank you, Dr. Muralidhar. The session is now open for discussion. We actually got the desk 10 minutes later, so we can have some discussion.
I think it's a very nice presentation, and really is a very courageous to show our complication. It really is good. And what about your complication? What you showed, the two things. One, you talk about the cataract following the GAT. So definitely you don't breach the capsule, but your suture has been gone down to the anterior capsule and probably rubbing the 360-degree. So it is reducing trauma to the lens capsule, not tearing it. That's why we got the cataract, first case. And second case, you showed very nicely that hyphema behind the lens. Probably this is the mistake when we do the initial GAT, we are making the goniotomy, and the goniotomy not at the level of the anterior tubercular meshwork. Most of the time we make the goniotomy that goes behind the posterior tubercular meshwork or sometime below the tubercular meshwork. So once we doing that, the suture is directing toward the ciliary body, not into the canal. So I think that's Dr. Moedin has told very nicely. Once you feel your suture is going too smooth, that means definitely you are not in the Salem's canal. You are going down towards ciliary body or above the capsule. But it's very nice presentation. And apart from that, what your topic is there? Not less invasive. Definitely it's less invasive, but really not less complication. Once you are not a monster, you can make a blunders while doing MIGS. And regarding this, when you begin the MIGS, I request everybody make your eye as much as soft you can. If you feel your pre-op IP is very high, give the Diamox, give ibumanitol, IP like 34 or 35, give ibumanitol, use Pilocar vigorously. Now, nothing wrong in using the Pilocar. When you're doing the GAT alone, use Pilocar, make your pupil constructed, and then do the GAT, bang, whatever you are doing. Even for the eye stent also, like Prasanna showed very excellent videos. So in especially when we have difficulty, we have the atypical angles where you can't identify the structure of the trabecular meshwork. You can use the Pilocar, pull the muscle, then you can easily find out, and the furrows will be little bit down, and you can easily visualize all the structure very nicely. Okay. And yeah.
Thank you, Dr. Devinder. Any questions from the audience? So as a beginner of MIGS, so I too face a lot of difficulties. One thing I wanted to ask, what is the type of anesthesia? So is peribulbar recommended for all of the MIGS procedures, be it with cataract or without cataract? So I would ask Dr. Venkatesh.
So I personally recommend for the general ophthalmologist who want to learn the MIGS, definitely would be the good anesthesia. Either you give the subtenance or whatever you give the perivulvar, but the anesthesia should be very good, and it should be eye patient should be comfortable. One thing, and recently, like we are doing the eye stent, we can do in topical once we are a master. I do my GAT in topical, but I don't recommend anybody to do in topical. But I recommend have the peribulbar or subtenance, whatever feel comfortable.
Any thoughts from you?
Sir, in one patient who had a pseudophakic where I did a G2 eye stent, So since that was not a part of the routine cataract, I was very comfortable going only with the topical, sir. But as you rightly recommended in the early stages, better to go for subtenons. Yeah.
Or you can use the intracameral lignocaine you can use, and then you can easily you can perform KDB, bang, because this short procedure you can easily perform. But when you talk about the God, we have to working on the 360 degree actually, and it's a lot of manipulation is there where you have to inflate the AC so many times, and sometimes when you inflate too much, it causes the pressure. That pressure occur to the iris, and really patient feel pain actually, and patient once uncomfortable, you become uncomfortable, it's difficult to do the surgery.
So
So for
initial mix,
GAT, peribulbar or subtenons is
Peribulbar
recommended, and for KDB or bang or eye stent under topical or intracameral lignocaine.
at the initial mix, I think comparing the cataract is much better. You get a deeper,
Deeper.
much
And you
safer.
do the procedure before the cataract surgery or after the surgery?
I finish Paco, then after do a GAT, whatever after the combined surgeries. They wonder how do you, there are such people who want to transit from topiclectomy to topical mix. What's your advice?
I strongly believe GAT. I do a lot of GAT, but I still feel GAT is not the last resort, because again in the GAT we are cleavaging the 360 degree. We are damaging the trabecular muscle 360 degree, though it's giving the wonderful result. But we have the data up to 4.5 years. I think it's still. I feel what the mix we should start that should minimum damage to the trabecular mesh work. So I strongly feel whatever the procedure you should do, save the rest of the trabecular mesh work for the future surgeries. So we have to intervene after 60 to 90 degree or 100 degree. So I will suggest you can do the Tedito hook microtrabeculotomy. This hook is not available in India, but it's a very excellent procedure having the very good outcome. Apart from that, people should start either by the trabeculotomy, KDB or bang. I think these should be the initial steps. Then later on, you should go for the GAT. GAT, I think, little tricky, have the steep learning curve.
At least after 30, 40 cases of this thing. Yeah, thank you.
Yeah, I think we'll close the session, and I call the speakers for photograph.